Hello, friends. Welcome to Veritas Podcast. I'm Dr. Hatemi. We have a special guest today. We have Dr. Kamran Koranloo. He's a pain management specialist, right?
Yes, good evening.
Good evening. Nice to have you, Dr. Koranloo.
Thank you so much for having me. Yes.
We have a lot of pain management patients, a lot of pain issues in the urgent care, and I think it would be very appropriate to have somebody who handles pain on a daily basis. And you're the master of pain.
Try to help. Yes.
Dr. Koranloo, you have a clinic, your own practice, right?
That's correct. That's correct. It's called Lake Carolina Pain and Spine Institute, Pain and Spine Center.
And your background is in anesthesiology?
My background's correct, anesthesiology. Yes.
And you did tell me more about your background. Like you did your residency in New York, I believe. Right?
Yes, correct. I did a 1 year of general surgery internship in New York, then did my residency in anesthesiology, Columbia University.
Oh, nice.
And completed my pain fellowship also at Columbia University.
New York City, Manhattan.
New York City, Manhattan, yes. Columbia Presbyterian Hospital.
So we have a very prestigious institution.
It is very nice. I was really privileged to.
And you work for the hospitals for a while, and now you have your own private practice.
That's correct, yes. I started my private practice in 2007, and then worked for hospitals for a few years, and then decided to return to. There's a lot of demand on chronic pain patients, and I didn't want to limit myself to one source of referrals and one source of patients to cover. So to expand that to cover more patients, I decided to just go back to private practice.
Private practice. We see a lot of patients in urgent care for pain. I mean, shoulder pain, back pain is a huge one. These are chronic patients, and we always feel bad. It's so hard to get in with a pain management doctor.
Correct.
And I'm glad to have you as a resource. So what are the main reasons of back pain? For your patient base, what are the main etiology of back pain?
As you know, there's a lot of familial etiologies, reasons. It runs in the family. It's a lot of degenerative changes. And all of us, when we age, it's like degenerative changes develop in your spine, from neck to lower back to the lumbar spine. And same process happens in every other joint, major joint in the body, as we all develop some sort of degenerative changes. Although some people become more symptomatic early on in their life, some people become more symptomatic later in life. And also, of course, depends on the job, depends on type of more physical jobs, more demanding, physically demanding jobs, obviously, are make you more prone to injuries over time.
And how successful is back surgeries, lumbar spine surgeries? Do you prefer treat them without surgery?
I always tell our patients we are the last station before surgery. So, as you know, it used to be the older school of thought was that early surgical intervention is good, outcome is good, the prognosis is good. It all changed, and after a very large study in Holland, in the Netherlands, and they did 10,000 subjects, and two groups, one early intervention, surgical intervention, one 2 years of physical therapy and non-operative measures. And in the first 6 months, the early surgical patients did better. At the end of 2 years, the non-surgical patients did much better. So complications, post-laminectomy syndrome, failed back surgeries. Of course, those are side effects or complications of surgery. So they changed. The school of thought changed after that large study. And now surgery is, as you know, it's the last resort thing for treating spinal issues.
I mean, from my experience, I don't know what your experience is on a daily basis, like cervical spine, neck surgery is usually successful. Back surgery is not so much. I mean, you will think like, okay, I have a back surgery and I will have no pain. But a lot of them come with worse pain. So I almost like feel like, is it like appropriate to, I really reluctant to send them to surgery because like usually they come back with pain. I was like, okay, why did I send you in the first place for surgery? And I see them again in the clinic. And I think surgery is not the best option for a lot of people.
That's right. I always, you're correct about cervical versus lumbar spine. There are reasons, there are technical reasons for more success rate with surgical, cervical spine surgeries. However, in general, the outcome of lumbar surgeries depend on the patient, depend on the reason for surgery, and the extent of surgery. As you know, the spine surgeries have become less invasive. We have minimally invasive discectomies now. We have smaller incisions. We have, even for fusions, they do fewer levels of fusion, which makes the outcome better. But in general, I always tell the patients that this notion of this is a fix, I'm going to have surgery like many other surgeries to fix my problem. There is no fix. This is to improve the mobility, improve the quality of life, the pain and range of motion. When things are at that level, they are so limiting in your quality of life. So when everything declines and you have exhausted all the non-operative measures, then of course surgery for the right person, for the right patient, is the right thing to do. And the number of lumbar surgeries have decreased over the last 20 years. That's a good news.
And there are less levels of fusion. You know,
Correct.
back in the day, there was a few 6-7 levels at
large incisions.
I mean, I had one surgeon like everybody got like 6 levels of fusion without even like differentiation, which is criminal almost.
That was the studies that later on did not support that, and now the fewer levels of fusion, the better.
And you cannot go back on that neither. You cannot really reverse it.
Do what
it's like a heart stent. You know, once you place it, you're stuck with it.
Right.
And so if I send a patient to you, say I have a patient with degenerative changes in their lumbar spine, what options do you have? What do you offer? I know other than medications, what kind of non-invasive, I mean, they're invasive, but non-surgical options you have?
What we do in interventional pain management, basically we utilize procedures from injections to nerve ablations to spinal cord stimulators to improve the pain, improve the quality of life. But it all depends on your comprehensive history-taking, physical examination, like any other field of medicine. And sometimes to make the correct diagnosis where the pain comes from, we call it pain generator or source of the pain, you have to perform some diagnostic procedures. So you block a nerve and you inject the joint and see what happens. And if that is successful, even for a short period of time, then you come up with a longer-term plan, like ablation of those nerves, that can last up to a year or sometimes longer.
What's your most favorite procedure you do in the office? Like, what's your bread and butter, like on a daily basis?
We do lumbar or cervical or thoracic. We do epidural steroid injections. We do facet blocks. We do sacroiliac joint injections. One procedure that I really like a lot because it provides long-lasting relief is ablation, is radiofrequency ablation, or RFA we call it. Mm-hmm. So you perform diagnostic blocks. If they come back with a 70%, 80% relief of pain, improvement of function, even for 3-4 days, then you bring them back and ablate those nerves. And for those nerves to grow back, it takes a long time.
So what you do, you do a nerve block first, see if it works?
You do the nerve blocks first, correct.
So if it works, then you go and then follow up and you do the ablation.
Exactly. That confirms that your pain comes from the arthritis in the joints, in the spine joints, which we call them facet joints. And once that provides the meaningful relief you're looking at maybe 70-80% improvement of everything, function, pain, then you bring them back for the ablation.
Incredible. And what do you think is the percentage of physical therapy? Do you think it's helpful? Do you think it's an important component of pain management?
Yes. We have, our ancillary treatments. We utilize physical therapy. We utilize even alternative medicine. For some conditions, even acupuncture works. As you know, chronic pain can affect every aspect of your life.
Absolutely.
From psychological aspects, financial aspects, even interpersonal relationship aspects, family aspects. So comprehensive pain medicine is not just focusing on the source of the pain and try to address that. You have to address the individual, that person as a whole, with all the other branches of their lives. So that's why it's comprehensive. That's why when it becomes more effective, when you utilize those. So I do referrals to pain psychologists. For instance, cognitive behavioral therapy, CBT, has been proven to be effective in managing many conditions with chronic pain. We utilize physical therapy, as you said. We utilize acupunctures. I send them sometimes to relaxation techniques. As we know, 70% of patients with chronic pain will develop, if untreated, will develop some degree of anxiety, depression, and mood disorder. So,
having back pain is definitely depressive.
Depressive. It's depressing.
You'll be depressed.
It's when you think that you can't do many functions that you would like to enjoy, then it becomes depressing. But you need to reverse that. We need to speak with the patient. Spend time initially. I'm a big believer in initial consultation to be comprehensive and learn as much as you can, as much as you from the patient. So you have to listen to their history, listen to their support system. Support system is like utmost importance in chronic pain management. So some people with better support from families, from friends, they do better in long term.
And the economic cost of back pain is tremendous in our society.
Absolutely.
I mean, like the days lost at work, the disability that comes with it. I see a lot of people, they just cannot function. I have people who own businesses, and because of back pain, they have been laid off in the bed for 2-3 weeks that they can even move. That affects their family life, their business, everything, every part of their life.
We believe we spend around $700 to $800 billion a year.
That's incredible.
On chronic pain. We think it's about 100 million Americans have one type of pain or another in their life. So it's common, and if untreated, it can lead to many other problems.
For clarification purposes, do you do nerve stimulators too? Do you place them?
Yes.
Okay, so yes. That's an option in your clinic.
That's another spinal cord stimulator. As you know, for the right person, for the right patient, can provide pain relief when they have failed including surgery, they have other measures. And basically, it's a symptom treatment. It's not going to the root of the problem. But a lot of people need that symptom treatment.
Absolutely. And how about neck? What do you recommend for the neck? Do you still also do injections in the neck? And
Definitely, yes. There's a lot of options for treating the neck problems, as you know, depending on if this is related to the disc problem, nerve compression. Then you have some certain injections for that. If it's arthritic related, without radiation down the arms or without causing weakness or numbness, then you can provide same diagnostic nerve blocks that we do with the lumbar, and then bring them back for ablation if necessary. We use physical therapy again for neck. Very effective. Depending on the patient's pain level, depending on the patient's needs, job, requirements, lifestyle, things they want to do, their age, and a lot of factors have to take into consideration.
You mentioned acupuncture. I'm a strong believer in acupuncture. Actually, when in medical school, I went to China for a month and studied acupuncture. I don't practice it.
Interesting.
My thing is, it's especially in Colombia area, it's hard to find a good practitioner. Do you have a go-to person? Do you have one person you recommend, or do you have any good acupuncturists in the area?
We do have a couple of acupuncturists. I just recommend it to patients if they want it. But most patients, when they ask if the condition is right and there's evidence-based effect of acupuncture, because acupuncture cannot be effective for every pain conditions, but for certain conditions, definitely we send them to make a referral, make a recommendation.
And in pain management also, the medical options, the pharmaceuticals, we have a big opioid epidemic right now. What you think about, but doctors are less reluctant to prescribe opioids now. And I think pain went from being overtreated to being undertreated right now, because a lot of doctors are scared to give opioids. The medical boards and the government is cracking down on doctors who are actually doing pain management and with those kind of medications. What you think about alternatives to medications? What you think about CBD, or what you think about THC in the treatment of pain?
There are, as we speak, clinical trials ongoing around the country, especially Veterans Administration medical system. They have a federally funded grant for these studies, effect of cannabinoids on sleep, on mood disorders in the veterans, on PTSD, on depression, insomnia. And there's a lot of conditions they're doing. As we speak, there's ongoing research going on. So once these results come out, we will know more as an evidence-based outcome. So far, it's been positive. There is no doubt there are certain conditions in chronic pain, again, for the right patient, they can be very effective.
So do you think it will change? I think it will be a game changer if we can actually make it mainstream, less stigma around it.
We are states, certain states in the country who basically have legalized, their legislature have legalized cannabinoids for certain conditions for medical marijuana, as you know, and there are some of them they have legalized it for any reason, medical or none. But we need to see the outcome in the studies, upcoming studies, to see what the results are in different conditions. Anecdotally, we know many people report good results and benefits for their sleep or PTSD conditions and others. We know they have cannabinoids have anti-seizure medication effect. They use them for intractable seizure disorders in children. As you know, it's FDA approved for that. And there are certain conditions, there's no doubt that there is a place for cannabinoids. They used to think that the receptors for cannabinoids are basically shared like with opioids. But there are definitely a different set of receptors in our central nervous system, CB1, CB2, and many subsets of receptors. So
it's not the only mu receptors?
It's not only mu receptors or other opioid-related receptors. So the notion of that I hear it a lot, that they can be gate medicine for drug abuse. And
I don't believe in that.
That has not been proven.
I really don't believe in that. I don't think it's a getaway drug. The problem is the overdose deaths in South Carolina, in Lexington County, doubled since COVID. And, it used to be less than 100. Now it's more than 100. Wow. And it was like 60, 70, I believe. I don't know the exact numbers, but I know it doubled of last 4 or 5 years. And if we don't open the doors for THC or cannabinoids and CBD, I think we will be in a trouble area, because people will get care, legal or illegally, and that's a dangerous with the fentanyl and all that.
There is a opioid sparing effect from cannabinoids that it's under study, and then that would be a game changer, because many people think that, or they have this misconception that this is addictive, or this is something gateway drug to addiction, but actually it can spare opioids. People who switch to cannabinoids to treat their symptoms, to treat their conditions, they tend to use less opioids.
Of course. I have older patients, and I tell them
all the time. Exactly.
And I tell them order online and get your edibles, I mean, and they benefit, they love it.
We see them a lot. Yes.
How about, so we always talk about neck pain, back pain, shoulder pain. How about migraine? Do you treat migraine patients?
We do, absolutely. If they see their neurologist, or they can come to pain specialist, chronic pain specialist, and once diagnosed, there are treatments, and we provide that, including, as you know, Botox injections can have preventive effect for 3 months.
You don't do the Botox?
Yes, we do.
Oh, you do Botox? Perfect. I have a lot of patients, they want Botox. And we have one provider, God bless his soul, rest in peace, Dr. Hammett. He passed away.
Yes.
And he used to do a lot of Botox injections. So there's a lot of patients out there looking for a home to come to for Botox injections, and I would refer them to you. The main thing is you need a referral to come to you. Which insurances do you cover? I mean, I know these are kind of topics we don't really discuss, but these are important. So for my audience, what insurances does your practice cover right now?
We take every insurance, except Medicaid.
Except Medicaid, you take everything?
Yes, we take everything else. And,
TRICARE, do you take TRICARE?
Yes, TRICARE. I've been a TRICARE provider for 22 years.
Okay.
And we are proud to serve our military active duties and retirees and their families.
TRICARE, Blue Cross Blue Shield,
Absolutely.
United, Medicare's. Okay, wow. That's a big range. So we would love to have you. I hope I can convince you to have a satellite clinic in Lexington one day. You're a little farther away from me. I mean, I still send you patients, but if you were here, I would love to. It's just so many people in Lexington County have no place to go for proper pain management. And there are a few doctors here. I mean, some of them are okay. Some of them I don't recommend. I won't give their names. I would love to have somebody like you to here to provide care to our patients. I mean, pain is a big issue, and they really undertreated. They're stigmatized. They labeled as drug seekers.
Yes, unfortunately, there is a tendency to stereotype and be judgmental about chronic pain. There's nothing to be judgmental about. It's a chronic condition like many other conditions, and it should be addressed. And there are, as I always tell the patients, chronic pain is a psychophysical, social phenomenon. So it's not just physical, it's psychological and social phenomenon. So you have to address every aspect of chronic pain if you want to be successful in helping your patient.
And there's a lot of stigma, a lot of misconceptions around it. I mean, I did pain management for 5 days because I was working in urgent care. There was a pain management doctor, and he ended up in the hospital for a surgery himself. So the doctor became a patient, and he asked me, hey, can you take care of my patients for 1 week until I come back to practice? And I did treat it. And then, I was surprised. I was expecting a certain kind of clientele, and I was seeing lawyers, judges, police officers, business owners, young people. So I was like, not the typical I was expecting. As a doctor, I was surprised that these are you look at people, they look normal, healthy, happy, young people, but they have horrible back pain.
Absolutely, yes.
I mean, they're devastating back, lumbar spine pain, cervical pain. And then I was like, okay, this is not your 70-year-old veteran who's been through a lot. They're hurting his back. This is a young man with young kids, but excruciating back pain.
Absolutely.
And I suffer from back pain. I mean, I don't have much episodes, but
I do too.
I mean, I literally, when I have back pain, I cannot walk from here to that Dr. Pepper. Like I'm stuck. I'm frozen in place until I get the shot. it is a very scary, very painful.
It is, and for a lot of patients, it can be a source of anxiety because they are worried about their future, they're worried about their job, their families, and am I going to be able, where am I going to be in 10 years, where am I going to be in 15 years? These questions always come to your mind and cause anxiety and nervousness. So we have to address those. To help your patient, you have to address those. And first, you have to identify that they exist, they're real. And if you don't ask, you won't get an answer. So we need to actively initiate in the conversations, ask those questions, be active about it, be proactive about it. And then a lot of patients will not tell you if you don't ask, or they don't think they're related. They think they can't sleep just because it's insomnia, and they need sleeping pills. But when you ask more questions, you realize, okay, this is a pattern of pain that affects their night more than daytime, or affects their evening time more, or vice versa in the morning. So you have to come up with the pain pattern, and pain behavior before you address the.
I suffered from insomnia. I refused to take medications for it. Now I sleep like a baby, but I found that there's a lot of things to it. We don't think about it, but it prevents us from getting a good night's sleep. I think one of them is eating late. Mm-hmm. You want to go to bed with an empty stomach. Your digestive system should be inactive when you go to sleep,
correct.
I think.
That's correct.
Another thing that helps is I found that decreasing the temperature of the room. I dialed down the thermostat to like 67 degrees because your body needs to cool down to sleep 2-3 days. And I had this weird habit of not be able to wear socks when I sleep. So I have to take my socks off. I cannot sleep with the socks on. And I have to have no blanket on my foot. It should stick out. And I thought that was like my quirky habit. It was something about me. But it's actually the science behind it. Mm-hmm. You use your feet to decrease your body temperature. So if your feet is covered, you cannot decrease the temperature. So you need to leave your feet open. No shoes, no socks, no blanket on it, just out there in the open. So you can use that to get rid of the temperature, body heat. So not eating late. And there's something about light exposure. You need to get enough light exposure during the day so you're tired at night. So if you don't so you shouldn't be in a dark environment all days for you to get a good night's sleep in there. So, and if you cannot get the sunlight, there is some lights indoors you can use in your environment. You can just put in your office, so you're exposed to UV lights in the same spectrum as the sunlight. Also, avoiding caffeine. Absolutely. That's a big one. Avoiding food late. Also, associating bed with just sleep. Not watching TV on the bed or not reading books, just to go to bed, sleep, so your brain associates sleep with the bed, not other activities. I think pain is also another reason people cannot sleep.
Absolutely. And if pain is not the reason they're not sleeping, and there are reasons other that you just mentioned, all the reasons about insomnia, then knowing those pre-existing problems will help you address the pain.
Absolutely.
Because then you can sometimes prescribe something that can address both pain and sleep, and doesn't have to be habit-forming sleeping pills, doesn't have to be anything.
Do you prescribe a lot of muscle relaxants at your practice?
For sure.
What's your favorite go-to muscle relaxant? Mine is Flexeril, but a lot of people don't like Flexeril because it's sleepy.
I use tizanidine a lot, just because has a triple action. Not only is a good muscle relaxant, but also helps with the sleep, because it does affect sleep center in the brain, and also has some effect on nerve pain. Symptoms like tingling sensation, burning pain, numbness, that basically are rooted in the nerves itself and the compression of nerve or spinal cord. For those symptoms, it's not the mainstay drug that we use, but if you have someone who needs muscle relaxation and sleep, most patients do have some nerve pain symptoms too.
How about diabetes, diabetic neuropathy? What options?
We see them a lot. thought, and whether they come to us for that particular condition or they come it and you recognize it during your examination that they have that problem in addition to their spinal issues.
But diabetic neuropathy, you have less options. Like you cannot do nerve blocks, or you cannot do.
That's very correct. That's true. But at the same time, the tight sugar control, blood sugar control. A lot of people, the diabetics, their blood sugar is poorly controlled. The diabetes is poorly controlled. But there's not enough exercise, but there's not the right diet, or they're not. There's no compliance with medications or treatments, so they develop neuropathies. And I have handful of patients who presented with severe cases of diabetic neuropathy, polyneuropathy, involving the legs, affecting their motor function and sensory function, and just because they were not compliant with their medication.
How much reversal do you see after proper glucose control or diabetes management?
I have 2 severe cases that it took them 2 to 3 years for reversal.
But reversal is possible.
Yes. Both patients are completely reversed.
I think we're going to have some breakthrough on that one. Compliance is an issue, especially in men. I mean, I'm not saying women. I mean, men are worse with compliance, I guess. Diabetes is a difficult condition to treat. I mean, you have to take your insulin 3 times a day, and then you have long-term insulin. It's a lot of medications to manage, and then it's your diet component to it too. It's hard to manage your diet. There are so many foods you are forbidden to eat, and those are like the best food. The rice, the bread, the donuts, all that thing. But I think this new medications like Ozempic and Mounjaro, I think we're going to see a significant shift in the management of diabetes.
I think so too.
Because once a week, you cannot mess it up. You don't have to remember it every day. You just remember, and then weight loss. I mean, people losing weight. Not just diabetes, that will help with their back pain. That's gonna
cardiovascular system, cholesterol, and everything.
I mean, I have a friend who's a cardiologist giving for patients Ozempic and Mounjaro for cardiac reasons. They don't even have diabetes; they have congestive heart failure, and they benefit from weight loss and those kind of things. And I think we are looking at the problem in a different way, just not managing the symptoms, but actually managing the problem, the under causing root cause, which is the excessive weight and the poor management of glucose levels. I think these 2 are significant. Hopefully, because diabetic neuropathy can be devastating. I mean, it can cause ulcers. I mean, that's a huge.
It can be very devastating and can have serious complications, intractable pain, and manageable. But again, early detection of the problem is the key, and early treatment is always the key.
I read it somewhere. I'm not 100% sure how accurate it is, or my memory can fail me, but Richland County was one of the highest rates of leg amputations for diabetes in the nation. I read it somewhere that we manage it so poorly in that population. Richland County is one of them. That the amputation should be a last resort. We should never amputate a leg for diabetes, but that becomes a common practice because we do such a bad. And insurance companies doesn't help by making it very expensive to buy these medications and not managing it. So I hope we get better coverage on Mounjaro, Ozempic. Insurance companies start paying for it, and pharmaceutical companies become more reasonable, coming down on the price
and more affordability.
But I'm glad we have more options now for pain management other than just pain medications. Opioids.
Oh, absolutely. Opioids have their own place in chronic pain management. I never rule it out, but there are certain conditions. Studies do not support chronic long-term treatment of pain with opioids. But there are studies also support some benefits in terms of functionality and quality of life. So for the right person, right patient, absolutely. And as you know, we have a range of opioids. It's not like they all have to be Schedule 2 or strong ones or potent ones, and the dose cannot be can be much the lowest effective one. So my general recommendation to my colleagues in primary care practice is always don't get involved in chronic opioid treatment for any of your patients, because once it's done, it's hard to undo. Once you put someone on 4 to 6 tablets of short-acting opioid, whether it is oxycodone, hydrocodone, after a few months,
It's not going to work.
That's one, and then two, you can't utilize other non-opioids. It's too late for that. So the receptors already have been exposed to opioids, and they respond to opioids in shorter period of time. Then the tolerance develops, dose has to go up, and it's hard to take it away from that patient who has really enjoyed and improved quality of life. But long term, we know that may not be true, may not be the case. So there's my recommendation is always just early on, you have a chronic pain patient, send them to specialists from day one, so they know from day one, because many patients don't need to.
So a typical patient that comes to your office, they already have the MRI at hand before they come, or you order the MRI often?
Varies. It varies. Some of them depends. Our spine surgeon colleagues, who are big source of our patients' referrals, they already sent them with MRIs and CT scans.
How about from a primary care or urgent care center?
Sometimes we see them with imaging, sometimes we don't. And we don't require to see patients without MRIs, because not everybody with back pain or neck pain needs MRI. So I like to evaluate them. If they don't have MRIs and beforehand, we still see them. Sometimes the source of pain is something else, and by detailed history and physical examination, you can determine that this is basically, there's no need for advanced imaging, because as you know, they are costly. MRIs are not cheap, and you have to find the right person with the right indication to order.
MRIs got a little cheaper. We find places that do less than $700.
Yes, there are.
Claremont, American Health Imaging, hospital settings, they can go up to $3,000-$4,000. So just avoid hospitals. Go to private imaging centers, that you will save a lot of money. Is there, before we finish our podcast, is there any advice would you give our patients about back pain patients? Like what should they avoid doing, or what they can do to improve their life instead of coming to the doctor?
My general advice is always try to have exercise on your daily programs. Whatever you do, set aside 15, 20 minutes of exercise. I think every person with any condition, at any age, can do a certain degree of exercise and physical activity. Immobility is basically is a killing factor. And the prognosis will get poorer and poorer with the lack of movement. So the body that moves, that body heals. So my advice is always, and then healthy diet.
Definitely.
Try to have more vegetables, more fruits, and less, as we know, healthy diet. We are not big in healthy diet in America, but these are my general advices. And there are certain conditions of work conditions that you have to just adapt. I mean, there are people with very physically demanding jobs that you have to help them in a different way, so their job is not compromised and their income is not compromised. So there are challenges in that.
And there's a lot you can do in the workplace: proper posturing, proper lifting techniques.
Absolutely.
Wearing braces. It's for certain things.
Exactly. Absolutely, you nailed it. Just posture, ergonomics, correct ergonomics, and do it right way.
Well, thanks for coming to our podcast. I'm going to put your information below the video so my patients will know how to get a hold of you.
Thank you so much for having me.
I'm sure after this video, there's a lot of people who will come visit you because we see a lot of pain management patients, a lot of back pain, neck pain, shoulder pain, and they really look for a good pain management specialist. So we would love to send it to you.
So much.
Thank you, Dr. Koranloo. Thanks for coming.
Thanks so much for having me.
Thank you.